This lecture will be about mandibular dislocation. In this talk, I will begin by discussing the normal mandibular condylar position within the temporomandibular joint. I will give a brief overview on temporomandibular joint anatomy and function. I'll describe the muscles of mastication and explain how they move the mandibular condyle within the temporomandibular joint to allow for various mandibular movements. I will describe the imaging signs of mandibular dislocation, and I'll show multiple case examples, and this will lead into the treatment of acute or chronic/recurrent mandibular dislocation. And then finally, I will summarize the key points. This slide demonstrates the normal condylar position as seen on panoramic radiograph. You can see here the left condyle is within the glenoid fossa of the temporomandibular joint, and it is posterior to the articular eminence. This slide demonstrates the normal condylar position as seen on axial and sagittal section CT. On axial CT, you can see the condyle is within the temporomandibular joint, and on sagittal CT, once again, you can see the condyle within the glenoid fossa of the temporomandibular joint, just posterior to the articular eminence. This slide is a basic review of mandibular anatomy. Pause the video if you want to review here, because this anatomy will be used and discussed in the slides to come. So now I want to review anatomy that's specific to the temporomandibular joint, and I'll start with the articular disc, which is right here. And this disc actually separates the joint into two separate joint spaces. There's the superior joint space and the inferior joint space, and they really are separate spaces, and they allow for different types of movement. So within the inferior joint space, the condyle will rotate, and that will allow for the whole mandible to rotate and for the beginning of jaw opening. The superior joint space allows for translation down the articular eminence, which allows for further opening. So here is the condyle in its normal closed position, and here's rotation. You just saw that. There's about 15 millimeters. The first 15 millimeters of opening are provided by rotation within the inferior joint space, and then the rest of opening comes from translation of the mandibular condyle down the articular eminence. And notice that the disc moves with the condyle because it's a translation of the entire mandible down the articular eminence. So here are the muscles of mastication. There are 4 main muscles of mastication and 2 accessory muscles of mastication. So the 4 main muscles of mastication are the temporalis, the masseter, the medial pterygoid, and the lateral pterygoid. And of the main muscles of mastication, 3 of them close the jaw, and only 1 of them opens the jaw. And hopefully when I show you where these muscles are located, what they attach to, you'll understand why that is. Now both accessory muscles of mastication help to open the jaw. Okay, now I'm going to try to draw these muscles of mastication and help explain the movements that they provide. So the temporalis muscle inserts on the temporal fossa and heads deep to the zygomatic arch and inserts onto the mandibular coronoid process and fans out like this, and this helps bring the jaw up and back. So you can imagine how that's a closing muscle. Okay. Now the masseter muscle inserts on the zygomatic arch and heads down to the angle of the mandible. So you can also imagine how this is a closing muscle. Now there is a superficial and deep portion of the masseter muscle, but again they both provide the same function. Now the medial pterygoid is going to be a little bit hard to show on this image, and I'll show it on future slides, but it inserts on the medial aspect of the lateral pterygoid plate. So I'll show it, let's see, as dotted lines because it's behind the pterygoid plate or medial or deep to it, and it comes down and then inserts on the lingual side of the angle of the mandible. And it's pretty much heading up and down. I should probably have drawn it more like this, because this truly is an additional closing muscle. So whereas the masseter is on the superficial side, the medial pterygoid is on the lingual or deep side of the mandible. All right. Finally, the lateral pterygoid inserts on the lateral aspect of the lateral pterygoid plate. And there are actually superior and inferior bellies of this muscle. I'm not sure, that may be too much detail, but the bigger, the inferior belly inserts on the condyle itself. And when it contracts, it brings the condyle forward, and because there is an articular eminence, it will actually bring the condyle forward, sliding down the articular eminence and opening the jaw. So that's why the lateral pterygoid muscle is the one main muscle of mastication that opens the jaw. This slide demonstrates coronal and sagittal section CT shown in soft tissue windows, and I'm trying to demonstrate the temporalis muscle. So start with the coronal CT. You've got this muscle belly going down like that, attaching to the temporal bone, the squamous portion of the temporal bone, and it heads inferiorly deep to the zygomatic arch and inserts on the coronoid, not the condyle, the coronoid process of the mandible. And here it is. You can see some of these fibers heading down on the sagittal section CT, and it's intuitive to understand how this helps to close the jaw. Here are axial and sagittal sections CT in soft tissue windows. And I want to show you the masseter muscle on this slide. So on the axial, the masseter muscle is superficial or lateral to the mandible. Oops. There we go. And on the sagittal section, here it is. This is just the attachment to the kind of the anterior part of the arch. So it's kind of heading like this. More out laterally where the arch is over here, the fibers are more vertical. And again, this serves to close the jaw as it contracts vertically. The lateral pterygoid is an important muscle because it's the only one of the main muscles of mastication that opens the jaw. And so here's just a diagram depicting the facial skeleton in an axial section. And you have the sinuses here, the maxillary sinuses. You've got the nasal cavity here. These right here are the pterygoid plates, here and here. And there are lateral pterygoid plates and medial pterygoid plates. The lateral pterygoid muscle inserts on the lateral aspect of the lateral pterygoid plate and runs to the condyle. and this muscle will bring the condyle forward. And you'd think it would pull it medially, but remember that this one is working at the same time. So the end result is the mandible comes forward, and if you can imagine on the sagittal view, the condyles will move forward down the articular eminence, they'll rotate and translate, and the mouth will open. Just so you know as well, the medial pterygoid attaches on the medial aspect of the lateral pterygoid plate, but heads down towards the mandible. So let's see if I can show you. All right, so here we have a CT section similar to the diagram, and again you have the lateral pterygoid plate, and on the lateral aspect of the lateral pterygoid plate you have this muscle, the lateral pterygoid muscle, that's inserting onto the condyle. This slide demonstrates the medial pterygoid muscle on coronal and axial CT images. So here in the coronal plane you have the medial pterygoid muscle inserting on the lingual side of the mandible near the angle right here, and it heads superiorly, and you can't see it on this slide, but it's heading towards the medial aspect of the lateral pterygoid plate. So the lateral pterygoid plate comes down like that, and the medial pterygoid muscle inserts on the medial side of that lateral pterygoid plate. And here it is on axial images here. And it serves, as you can imagine, to close the jaw. The accessory muscles of mastication are the anterior belly of the digastric muscle. Here's the posterior belly, but the posterior belly is not considered an accessory muscle of mastication. The mylohyoid muscle is here, and that is also an accessory muscle of mastication. So both of these muscles insert onto the hyoid bone as well as onto the mandible. And you can imagine if they contract in this direction, the chin will come down and back and the mouth will open. And interestingly, both of these muscles, the anterior belly of the digastric muscle and the mylohyoid muscle, are innervated by the trigeminal nerve, which is also the nerve that innervates the muscles of mastication. The posterior belly has a different innervation by the facial nerve, and again is not one of the accessory muscles of mastication. So here I have sagittal and coronal section CT. I'm trying to demonstrate the accessory muscles of mastication. So on the sagittal section CT, we have the anterior belly of the digastric muscle attaching to the mandible here and the hyoid bone here. And you can imagine how it would pull the mandible back and help open the jaw. This hyoid bone at the moment happens to be pretty high. Sometimes the hyoid bone is here, and then it becomes a little more clear how it would bring it back and open the jaw. This patient may have been swallowing. That's what happens when you swallow, as the hyoid bone elevates. So on the coronal section CT, it's really hard to demonstrate the mylohyoid muscle because it's an obliquely oriented muscle, and so I can only really get it in the coronal section, but it attaches to the hyoid bone and like a sling inserts onto the mandible. So it's hard to demonstrate why it would create opening, but on that diagram that I drew earlier, where the mandible is like this and the hyoid bone is here, the mylohyoid muscle goes down like that and helps to open the jaw. Here's a quick review. The three closing muscles of mastication include three of the main muscles of mastication, the temporalis, the masseter, and the medial pterygoid. And then there are three opening muscles, which includes a main muscle of mastication, the lateral pterygoid, as well as the accessory muscles of mastication, the mylohyoid and anterior digastric. All of these muscles are innervated by the trigeminal nerve. Here are the imaging signs of dislocation. The first is the MTTMJ sign, which basically is seeing the temporomandibular joint on an axial CT and not seeing the condyle within it. That's the MTTMJ sign. Second sign would be malocclusion. So here, clearly these teeth are not coming together. It looks like the lower jaw is out in front of the upper jaw, which can be the case normally, but tends to not be. But this is really tough on imaging because you as the radiologist, you don't know what the patient's normal bite is. If they're opening their mouth during the scan, you really don't know. So the malocclusion, you can see it on imaging, but it's more of a clinical diagnosis. And then finally, this kind of nails the diagnosis, is when you see the condyle completely anterior to the articular eminence. Now, below it can be completely normal. That could just be normal opening. But really, it should never go anterior to the articular eminence like this case. All right, let's do some cases. So case 1, the chief complaint was written as jaw problem following seizure. And here on the axial CT shown in bone windows, you can clearly see that the condyles are not within the glenoid fossa as they should be, and they are anterior here and here. This is the same case shown in 3D reconstructions. You can see that the condyle right here is again anterior to the articular eminence and not within the glenoid fossa here. Same on the other side. This slide demonstrates the dislocated mandibular condyle, with the condyle being anterior to the articular eminence there. And it also demonstrates the temporalis muscle, which attaches to the coronoid process here and then will fan up to insert on the temporal fossa here. And you can see that this muscle will contract and pull the jaw back and up. And so if this is active when this condyle is anterior to the articular eminence, you can see how difficult it is for this condyle to go back down and back into the joint. This is case 1, post-reduction. It's fairly standard to get post-reduction radiographs, although clinically, if their teeth fit together and it feels good to the patient, that's really the gold standard for determining that the condyles are in the appropriate position. But like I said, it is standard to get post-reduction radiographs. I would get a panoramic radiograph. I just think it's easier and more reliable to see the condyles. These oblique radiographs try to get the right condyle on one and the left condyle on the other. I think you can see the right condyle here. You know, it may not be fully seated within the joint, but it's clearly posterior to the eminence there. Here's the condyle. And on the other side, I really have no idea. It's somewhere in here. But again, I would prefer just to get a panoramic radiograph. So I made up the chief complaint for this case. Quote, "I can't close my jaw." And then I realized that if somebody really couldn't close their jaw, they probably wouldn't be able to say, "I can't close my jaw," or it certainly wouldn't sound like that. But anyways, I left it. I thought it was kind of funny. This patient, actually, this was a real patient that I saw when I was an oral surgery resident, when I was an intern. And really, this patient, it had happened to her before, so she knew what was going on. And you can see here on this panoramic radiograph, clearly the teeth aren't together. It's the first thing you might notice. And again, it's not real easy to see where the glenoid fossa is. you may think that this is the articular eminence, but it may not be. And a lot of times the zygomatic arch, there's a little eminence of the arch itself that superimposes on this area of the radiograph, and it can look like the articular eminence, but it's not. Certainly this patient was dislocated. So this is the patient after manual reduction. So I moved the condyles back into position and took a post-reduction radiograph. So you can see here the condyle is further back than it used to be. So I think this was that zygomatic arch eminence that I was referring to. And I think on the previous radiograph, condyle was probably right here. And it looked like if this were the eminence of the articular eminence, that it would be in an okay position, but in fact it really needed to be back here. And you're just not seeing the articular eminence very well. I think what you're seeing here is the zygomatic arch. I just want to talk briefly about anatomy on panoramic radiographs. Here is the articular eminence. Here is the condyle. You can see they didn't get all of the condyle on this radiograph, and ideally they would. What I want to make note of is this. That is another little protuberance of the zygomatic arch. It's probably related to the attachment of the masseter muscle, but I wouldn't want anyone to confuse that with the articular eminence. So if the condyle were here, you could imagine that you might think, oh, here's the articular eminence, here's the condyle, it's behind the eminence, it's fine. And if the tech chopped off this part of the radiograph and all you saw was this, you could think that the condyle is in the right position behind what you think is the articular eminence. And so I'm calling this the pseudo-eminence. I haven't heard it described that way, but just be mindful of that. Now, if that were to happen and this condyle was truly in front of the actual articular eminence, the mouth would be open. The mouth would not be closed like this. But sometimes patients, even though they're supposed to have their teeth closed when they take normal panoramic radiographs, open their teeth. So keep in mind of this finding. Again, on the other side, you've got this pseudo-eminence, and then you have the real articular eminence. So if you're curious how one manually reduces a dislocation, I'll tell you. Give the patient a lot of pain medication, maybe something to help them relax, and then wrap your thumbs in many, many layers of gauze. Tape it all together so you have big padded thumbs, and then you put your thumbs on the patient's lower molar teeth, so kind of the back teeth on the bottom. So your thumbs are in the patient's mouth and you want to push down, because remember the condyle is anterior to that eminence. You can't go back. It just runs into the eminence. You have to go down below the articular eminence and then back. Now when you do this, often their jaw will kind of snap back into place because their muscles have been in spasm for a while. And so that is why you pad your thumbs. So wrap your thumbs in gauze, go down and then back. And that should do it as long as the patient has enough pain medication on board. Case 3 is an interesting case I saw on my nuclear medicine rotation. So this patient was getting a PET scan because the patient had lung cancer, I think. And when I was scrolling through the head portion of the exam, I noted that the left condyle was in good position within the joint, but the right condyle seemed anterior within the joint, or maybe even partially out of the joint. So I kept looking, and again, you can see on the sagittal section CT, indeed it was kind of subluxed partially down the articular eminence. And I noted on the PET scan that the right lateral pterygoid muscle was really hot. That means it was taking up a lot of glucose. It was very metabolically active. So what I think was happening is, for one reason or another, this patient's right lateral pterygoid was in a little bit of spasm. And I thought it was just a very interesting case that shows how contraction of the lateral pterygoid will cause translation of the condyle forward and down the articular eminence. So let me talk about the treatment of recurrent or chronic dislocation of the mandible. So this is when a patient has repeated episodes of dislocation, and again, I'm talking about when the condyle comes anterior to the articular eminence. So what can be done? Well, surgically, people have thought about lengthening the articular eminence so that it can't come in front of it. That's one option. The other thing that people have thought of doing is shortening the articular eminence. That way, if it does come forward, it easily slips right back. And as I showed you in that last case, the lateral pterygoid muscle is actually thought to contribute to these cases of recurrent or chronic dislocation, that there's either a hyperactivity or a spasm of the lateral pterygoid. So some treatments are aimed at the lateral pterygoid muscle itself, including a lateral pterygoid myotomy or a Botox injection. It's important to note that patients who are edentulous often have chronic dislocation because they don't have the teeth that align their bite in a reproducible way that leads to sort of muscle memory that keeps the condyle seated in the temporomandibular joint. So these patients often have chronic dislocation. It's not necessarily something that even needs to be treated. So if you see this on a edentulous patient, you can mention it, but I wouldn't make too big of a deal of it. Now I want to summarize the key points of the lecture. We started off by reviewing anatomy and the condylar movements within the temporomandibular joint. And remember, there were two different joint spaces separated by the articular disc, a superior joint space and an inferior joint space, with rotation in the inferior joint space and translation down the eminence in the superior joint space. And it's the translational movement that leads to, it's normal, but when it's extreme, can lead to dislocation. And we learned how condylar dislocation typically occurs anteriorly and inferiorly in front of the articular eminence. We reviewed signs of dislocation. We reviewed the muscles of mastication, and we focused in a little bit on the actions of the lateral pterygoid muscle, as that is thought to contribute to dislocation. And we reviewed the treatment of both acute and recurrent condylar dislocations.